Welcome to the Health Fix podcast, where health junkies get their weekly fix of tips, tools, and techniques to have limitless energy, sharp minds, and fit physiques for life. Hey, health junkies. On this episode of the Health Fix podcast, I'm interviewing Dr. Robert Whitfield, and we're going to be talking about breast implant illness. Dr. Robert Whitfield is a board-certified plastic surgeon with over 26 years of experience. He specializes in breast implant removal surgery, breast implant illness, and advanced cosmetic procedures. He was born and raised in Las Vegas, Nevada, and received his medical degree from the University of Las Vegas School of Medicine. He then completed 6 years of surgical training, including a plastic surgery residency at Indiana University Medical Center. Now, he is now practicing in Austin, Texas, where he has become renowned for his cosmetic expertise. He is definitely passionate about helping women understand the importance of advocating for your health and understanding that breast implant illness can cause chronic inflammation in the body, and it can wreak havoc on your entire immune system. And of course, it can cause a variety of health problems, including imbalanced hormones, loss of libido, difficulty losing weight, and a lowered ability to detox from environmental toxins, heavy metals, and mold. So, Dr. Robert Whitfield has a ton of information for us. Let's introduce you to him so you can learn more about breast implant illness. All right, folks, I got Dr. Rob on today, and we're going to be talking about breast implant illness, something that I've been seeing in my office quite a bit. Folks are asking me questions and also looking for qualified docs that know what's going on in this department. So, Dr. Rob, welcome to the Health Fix podcast.
Well, thanks for having me on.
So, big thing here, of course, that everyone wants to know when they first find out that a doc is specializing in breast implant illness. How did you come to specialize in this department?
We traditionally, in my practice, had taken care of breast cancer patients predominantly. So I taught microsurgery for breast reconstruction and for head and neck reconstruction and sarcoma reconstruction for many years. And then I left the academic setting and went to Austin in 2012. And I joined a group practice and basically did the same things.
Mm-hmm.
And we would always see patients, whether they're cosmetic or breast reconstruction patients with implant related issues. Sometimes they would just come to me specifically for expertise regarding a malposition. So the implants were not at the correct levels, or they may have had a capsular contracture, or they may have had problems with radiation injury or, infections or something like that throughout, the course of their time with implants, either from breast reconstruction or from cosmetics. And in 2016, I had a patient come who was a breast cancer survivor. She had an implant-based reconstruction done in Georgia. And she had retired in Austin and didn't want her reconstruction anymore. She wanted to be flat. And from time to time, patients reach that conclusion or that point in their life, and they no longer want a breast reconstruction, and they'll seek advice about what to do about it, what techniques. And we did her workup, and there wasn't anything concerning. Totally agreed with her decision to do that. So she had to be taken care of at a hospital. She had an underlying medical condition, so she needed an overnight stay. So I did her case, took out all the capsular material and the old implant material, sent it all off to be examined for pathology to make sure there's no recurrent cancer, because you obviously want to make sure that in a breast cancer survivor. And then you always look for any signs of infection in the pocket. And on her results of pathology, she had no recurrent cancer, but she had on her microbiology, which looks for bacteria and fungus and mycobacterium, E. coli. And the amount of E. coli she had was consistent with an infection. So she had an underlying infection this whole time. The only symptoms she really, gave us that was a hint, in retrospect, was she had fatigue. But I've taken care of cancer patients since the 90s, and many of them through bone marrow suppression and their therapies have fatigue. So that's a pretty routine, issue for them. So my sister's a breast cancer survivor, and I would have been really upset if someone had missed an infection, on my sister. And when I went back through all the notes and exams and encounters we had, and I couldn't find, anything that would give me a clue about that. So I put her on antibiotic therapy based on what the culture showed and the sensitivity patterns of the culture. And within, 2 weeks, she was doing much better. And at a month follow-up, most of her fatigue had resolved. So she had uh, fatigue due to underlying infection.
Hmm.
And once that was removed, she obviously did better. And that's all documented. There's no question about it. From that point, I believe she put me on a message board through either Facebook or other um, boards. And I started having people self-refer to me to do explants. And having that, encounter was very concerning to me because then I didn't really know how to rely on the information we were being faced with because none of it had given me an idea that there was a problem. So if someone came and wanted their either breast reconstruction or cosmetic augmentation uh, taken out, and we went through the process with them, I would help them, do that. Now, fast forward, I've done probably over 1,800 explants for both, predominantly now cosmetic patients, but I just had a cancer patient on yesterday from California, and they've had lots of problems with autoimmune issues and with fatigue and, just all these symptoms of chronic inflammation. So for the audience, so when people ask me what I consider to be breast implant illness is, to me, it's a chronic inflammatory process,
Hmm.
and it doesn't lend itself easily to a diagnosis, and that's why it's super confusing to providers. So it does have a component where there's a medical device, and in my opinion, it could be a number of devices involved with something like this. It could be a hip, a knee, a breast, a dental, cardiac, spinal implant, whatever. Any of those things that are foreign can lend themselves to having biofilm and become a problem for your immune system. But there are always other factors. So we look at folks' genetics because you only have a certain amount of genetic capability to detox. And once you exceed that, you'll have more signs of inflammation. If you're faced over and over again, either through your environment, like where you work or where you sleep or where you live, you'll get exposures, chemical exposures, depending on the water. You may have things in your water like arsenic. Groundwater can be contaminated with arsenic very routinely. I know where I grew up, it was. You can have other problems, heavy metals. You certainly can have, and we see a lot of this in Texas, mold exposures. So, I mean, there's a number of things that affect you, and we know the food sources are not getting better; they're getting worse. So, glyphosates are typically a problem. And then I look at people's food sensitivities. To be frank, you could be eating and trying to do very well, but if you don't understand certain things that stimulate you, not just gluten and dairy products, but maybe an avocado or something, you never know
Sure.
what's going to cause a problem. And then we evaluate everybody's hormones. So like we paint this big broad picture to figure out systematically what is going on. But to me, it's just breast implant illness is chronic inflammation. The device is one component of it.
Sure. Sure. And this is something that, I think a lot of patients will see coming into my office. And because we're getting more and more traction with folks talking about breast implant illness, it's often the first thought that if they do have implants, they're like, that's got to be it. That's got to be my problem. And I'd love for you to kind of speak about how you had just said there's more factors there. So I guess one of the big things is probably how do we know if someone's suspecting, how do we know for sure? What would be the test that you would put them through to look at the actual implant? Is it an ultrasound? Give folks a little scoop of like, yes, maybe we might do genetic testing, maybe we might do the food sensitivity. But if someone's like, do I have something going on with my breast implants? What would be the first thing you would do to kind of rule it out or make it as a possibility?
Yeah, to be honest, on physical exam, people can have no findings. And then on MRI, ultrasound, mammogram, they can have no findings. So there's not a specific diagnostic study that's going to help you say someone has that problem.
Mm-hmm. Mm-hmm.
I don't worry about them anymore. So I don't, I consider somebody who's had devices, who's having those symptoms, who's done the standard allopathic workup. and that's been negative. And they've been to usually patients come to me after they've seen multiple specialists
Hmm.
and integrative practitioners and not gotten resolution of their inflammation.
Yeah.
So it's not I can tell you after I do an explant and send it off for PCR analysis what's on it. And about a
Hmm.
third of the time, it has biofilm, and that biofilm is usually Cutibacterium acnes, which is found in large concentrations. It's a bacteria found in large concentrations on your chest, face, shoulders, and neck.
Gotcha. Interesting. So transfer would have happened during surgery or what's the no idea, just something that's where it
Most
landed.
commonly, it would be hematogenous spread. So, I
Okay.
mean, the three likely routes for the audience for someone to get a contaminant, it would be at the time the device is handed to the surgeon putting in the device, and the third would be hematologist. That's the most common, obviously. So if you got a cold, a urinary tract infection, a GI problem, and those bacteria get into your bloodstream, or somebody has a skin infection, or in this case, acne, it gets picked, erupts, it gets into your bloodstream. I mean, this is going on forever. That's why, typically any patient having a mechanical valve or prosthetic placement of any variety, like a joint or anything, obviously you make sure their teeth are fine. You make sure they don't have an infection because if that becomes bloodborne in or around the time of their procedure and it contaminates their device, then you've cost them quite a bit. That's a very difficult problem once that begins.
Hmm. Hmm. No, absolutely important. So I think, one of the things that I wanted to talk about today, especially for the folks who are contemplating, do I have something going on? What kind of things do we want to consider, pros and cons of an explant, things of that nature? What do you usually talk with folks about in that department when they're coming in and saying, hey, I've got these factors, maybe, it's been identified that there is a low grade inflammation, infection kind of thing. Maybe they've gone to the point where they've got autoimmune things happening. What's kind of the evaluation and discussion that you have in the office about pros and cons of explants?
Well, usually the folks are really, I don't convince anybody really to do anything.
Hmm.
You convinced themselves before they ever show up. They're very self-selected to this point. They've
Yeah.
decided they don't want to have devices anymore.
Hmm.
So it becomes a discussion of, what fits them in their situation. Some people just want to have the explant done and they want to work with their practitioner and try to recover, and they're not really interested in anything else. Others will have interest in, if they, for instance, had a wider breast or low set breast from uh, pregnancies and child and breastfeeding, et cetera, then they'll want some kind of rejuvenative procedure.
Hmm.
Um, and then there'll be a group of folks who are just super concerned about they've had implants for a very, very long time. And this is the aesthetic they're used to. And if it changes abruptly, what's that going to be like for them? So
Hmm.
we provide all levels of, surgical service to help that, whether it's the explant alone or an explant where we do some sort of reshaping or lifting procedure. And then, of course, I do, and a lot of people come for fat transfers, which I do simultaneously a lot. But to get a fat transfer with us, or pretty much any procedure with us, you run through our program. I've done over 1,800 explants, but I have a specific program we put people through our heart program to help just level the playing field for them. We know it lowers inflammation to a certain degree, but actually to get all you know, if you want to get back to their baseline or whatever that new baseline is going to be for them, we feel that the device, if it's really acting as a big generator, has to be removed.
Okay. Okay. Let's talk about your program for a little bit because I saw on your website you've got a lot of different things in terms of binders and clearing and glutathione and things of that nature. Is that something that is on the forefront of the program, helping folks to detox better, working on maybe genetic mutations within the liver cells? And then on the back end, after removing and the explant, I'm guessing you have a specific procedure as well that goes on.
Yeah, the surgical program runs for a year around the time of your surgery. So we try to get people started on a laboratory evaluation. So we have those genetic tests, toxicity tests, food sensitivity, and gut microbiome testing, as well as we'll look at hormones and other traditional lab values. We got to get all that done up front to see like what is your specific set of issues. So if you had a bad mold exposure, if you had heavy metals, if you have a bunch of glyphosates, phthalates, BPAs, whatever, we want to start working on that now. We don't want to react to what's going on after surgery. We want to be upfront and proactive with that. We're very clear on the genetic predisposition of this patient population. Many of them have problems with vitamin D, metabolism, methylation, glutathione, and antioxidant pathways. So all of our supplements geared towards lowering inflammation, the majority of them are liposomal, so there's no issue with gut absorption. And we know those work to help lower inflammation. We've got plenty of experience with that. We then set up somebody to work with our detox practitioner if, in fact, there's a bad or series of bad findings on the toxicity test. And we do almost a little preliminary phase one detox with Cellcore, who we partner with, and then surgery. And then there's that, period of time after surgery. So I see folks the first week after surgery, a month, 3, 6, 9, and 12 months. But that's the surgical follow-up. The detox follow-up usually is running 3 and 4 month intervals concurrently to that.
Wow. Wow. So definitely a lot heftier of a program than I have seen with other docs out there, because it seems that it kind of runs the gamut. And I'd love for you to kind of explain a couple of things, because I have had patients who've come into my office and have done kind of a little bit of detox beforehand, afterwards, explant surgery. Then it's just, okay, now your body's going to return to baseline. So I'd love to kind of have you give a little, I guess, probably in what you've seen with those 1,800 cases, the detox component, the follow-up, and going through for a whole year. Because a lot of folks might be thinking like, oh, wow, a whole year. This is quite intense.
Yeah, I mean, if you had a pair of implants, I mean, I guess on average, I've got people with as short as a few years, and I've got people into having implants for 30 or 40 years. So
Hmm.
if you've had something, we'll just consider a inflammatory process for many, many years. We're not going to solve it in a week or 2 weeks or 2 months or maybe even 2 years.
Hmm.
It's not that easy.
Hmm.
So, depending on your genetics, depending on your already existing exposures, how you eat, drink, the air you breathe, it's going to dictate the large majority how you recover. So, our program is set up to help you recover efficiently by acting preemptively on things that we already can identify and work on with you. And then post-operatively, it's more about maintaining a certain diet and then modifying the things you can control. Everybody can control better their water and the food they eat. The food in this situation is the thing, along with supplementations, that's going to help you heal. So we already leverage the lymphatic system. I don't use drains during surgery anymore. We use hyperbaric oxygen in the office. We encourage folks to do both those things on their own as well. Um, but principally, instructing them on diets, making sure that their diet's helping them, not hurting them, and then letting them recover over time.
Hmm.
Everybody's, short of those who are infected, they're going to recover at different intervals.
Hmm. Hmm. That makes sense. That makes sense. So there's a lot of different folks out there kind of sharing their stories on Instagram and social media, and there's definitely some myths around breast implant illness and really implants in general. I'd love for you to share like the most common things you hear, what you're working with in terms of helping dispel these kind of myths with patients when they come into the office.
Yeah, I believe in 24 we'll have our study out about biofilm. So,
Mm.
you know, we'll have the largest experience with that. I think we had in that study 943 consecutive samples, something of that nature. It's over 900, and it's 30% is the rate of biofilm in that study, and the incidence, and then the bacteria, as I said, is key bacterium acnes. I think there's a lot of things that are kind of spewed on the internet about mold
Yeah.
and moldy implants and this and that, and that's not the case. I have, I think, 6 instances of that out of 1,800.
Interesting. That is something that I hear quite a bit from patients that they'll come in and say, "Hey, I had mold in my home. I swear my implants have to have mold all around them." And then of course comes in a Instagram story or something of that nature. So that's interesting.
Yeah, I mean, honestly, it's not compatible with life to have a bunch of mold around your implant. That's not going to work. So that's a myth. It's not accurate. Beyond that, I mean, the other fallacy is like, people are magically going to be better right after the surgery in the recovery room. Everything's going to change and it's going to be this epiphany. I would say that's an unrealistic expectation to set. Um, Many of these cases are not um, they're not easy to do. They may have had multiple surgeries. People may be relatively unwell to begin with, and so that's why we work with them up front. So I think it's a very unrealistic expectation to place on a poor, a patient who's not, they're in a vulnerable situation to begin with, and then to make it appear as though this is just going to be the uh, change all of a sudden after surgery. I mean, I have taken care of folks who've done and gotten better really quickly after surgery, and I would love for everybody to do that, but I've done, like I said, over 18. It's not the case in the majority of instances.
Oh, I'm glad you're mentioning it that way because as society is, we want the quick fix. And, of course, we would love for the breasts to come out, explant surgery done, and then all of a sudden you're this new person, you drop 100 pounds and you feel amazing. And unfortunately, working with women, being a woman myself, we want those things, especially with our body and shape and things of that nature. And so when it doesn't happen, I I will see folks who will come in and say, yeah, I don't feel better. But I love the fact that you're explaining, like, hey, this is something that you had the illness before. Maybe you had the predispositions with genetics, things of that nature, even going into this. So it's quite important for folks to really realize that as a whole. And that's why I was very interested in the fact that you have a year program because I don't see that quite as often with some of the folks that I've seen that have had explants and come into my office. It's like surgery done and you know
Well, I
figuring
can't operate on everybody, obviously. So
sure.
everybody can come to Austin. So people can run our program remote. So, we feel like we can help more people that way. I feel, there's a lot of good surgeons
Hmm.
trying to help take care of these patients, and I obviously can't do them all. But our team is set up to work with folks and to help them and take advantage of what we know. And next year, I'll have a book coming out just about the surgical program.
Okay, nice, nice. I think that's really important for folks to hear, especially for those that have a little bit more going on heading into these things. So, of course, one of the big questions I get from folks is with the genetic testing. A lot of folks have done 23andMe, and I usually explain that it's probably going to be, depending on whoever you're seeing, a more expanded DNA test.
Right, right,
Are you
right.
using DNA company? Who are you using for the DNA testing, just out of curiosity?
Yeah, I've used, well, I had this discussion last night with a bunch of people, and I've been curious about genetics since I was in college, which seems a very long time ago now. But, with the advances in computing and the completion of the Genome Project, now as they go back and look at it, you just learn more and more. And we do have a strong relationship with the DNA company. There's a new company, Envision Labs, that we're going to be looking at. So we want to always provide, clients with the best options genetically. And what everybody, our goal is to try to really tailor the experience. So
Mhm.
if I can understand better what your genetics are, you know, how do you metabolize something as simple as fats? Like you can really modify a diet. For instance, somebody says a keto diet doesn't work. Well, of course, a keto diet works. I mean, come on. The only thing that fails in a keto diet is when you start adding too much fat in the diet. If you can't metabolize fats, then you fail because your body can't handle that. So, I mean, ketones, like you would be dead if ketones can work in your body. So, of course, a keto diet can work. It just depends really on your metabolism. So, when we look at genetics, we're trying to be more precise about how we tailor the experience for the patients, including their anesthetic experiences. So in 24, in the new year, we're looking to really add more and more pharmacodynamic information to our plans so that we can help our anesthesia providers, who are all great anyway, but they need as much information to make that part of the case more efficient and simple for our patients.
That's neat that you're even thinking about that because, this is something that I think a lot of folks wouldn't really think of as part of their process. And obviously, detox of the anesthesia is just important of detox in general of environmental toxins and things of that nature. So that's fascinating to me as a genetic geek going, oh wow, we're looking all the way into types of I'm guessing types of anesthetics, how much different types of protocols that you might run in IVs while they're getting surgery too, or give us a little breakdown on how that kind of looks just in general.
Well, you want to know how certain folks will metabolize things like narcotics. So
Mm,
nobody really wants to take narcotics after surgery. And we minimize that in our program by running what's called an ERAS, or early recovery after surgery, and or enhanced recovery after surgery. The program we run starts the night before with things to calm down the nervous system, reduce inflammation, reduce nausea, and runs for the first 2 weeks after. The things with understanding more about, not so much the inhalational agents that the anesthesia folks have to use, but then the drugs that they may need to give IV, how they're going to respond to those. And then afterwards, for our clarity, trying to work on what would be the best situation for them from a narcotic standpoint or just anxiety standpoint. If they need things, what would work better for them? And certain, like somebody has a P450 issue, they'll require a different type of plan versus somebody who doesn't.
gotcha. It's fascinating stuff, and I think a lot of folks maybe, if they've gone down different rabbit holes of research online, they might have gathered some information, but as a majority, I think a lot of folks aren't thinking about these kind of things going into a surgery. So one of the other questions I get, and I'd be curious, Dr. Rob, as to your thought process on this. I have some clients who have old implants who are now having some leaking, and they're let's put it this way. We did a ultrasound on one gal maybe a couple months ago, and it looked like her silicone was leaking out of the implants. And she went to a specialist. Specialist said, they're leaking, but you've had them this long. It's probably not an issue. I would love to hear kind of how you talk with folks about situations like this. Is it more possible for a leaking implant to cause illness in someone? Give us a scoop on that so folks can understand a little bit better. And the type of implant too, silicone versus saline versus that situation.
Well, all the devices have the same shell, silicone or saline. So it's always a silicone shell. If there's a device failure and a saline implant, it goes flat. So that's an obvious, and they would show up with a change in the volume because it would have leaked, and that salt water that it should have been inside the device gets absorbed. So that's an obvious one. I mean, a silicone device that's failing or leaking needs to be removed, whether it's a cancer patient or a cosmetic patient. It's not appropriate to leave that in.
Okay, good to know. Good to know. Is this anything that you come up against in terms of patients? How common is it for silicone or even saline implants to leak that you see?
Uh, I would say I don't see ruptures that routinely in implants placed after 2013 because of the shell technology, but implants placed in the 80s and 90s, I do
Okay. Okay.
routinely. Yeah.
Okay. And out of the patients that you've seen that have been maybe more severe or let's put it this way, more severe. Let's go with that. Do you find any correlation to the older implants compared to the new, or it doesn't matter based on, what they're coming in with in their bodies kind of
Yeah, I,
predispositions?
I think the complexity of the question belies the testing and what you find on them. They're all each going to be their own unique case. When you try to put all those together, that's a hard one for us. I mean, we see folks who've worked, they've probably seen a practitioner that's helped them from an inflammation standpoint, and I mean an integrated practitioner. So they've already probably at that point tried to do some things outside of the box. So
Mhm.
it's, kind of that question's not a fair fight for me anymore because the patients I see are so selectively biased towards, coming to me.
Sure. Sure. Yeah, I could see that. I could see that. I'm just kind of thinking of some of the questions I've had in my office before and different things that folks are asking me. One of the other things that I get asked a lot is it common when you have breast implant illness to also have be more predisposed to breast cancer and cancers in particular?
Oh, I mean, that's a good question. I've had two instances of breast cancer and one instance of a lymphoma in all those cases.
Mhm.
There will be people who go on to have breast cancer because it's such a prevalent condition, but our body has this surveillance system with the NK cells that helps reduce our susceptibility to cancer. And then breast cancer's obviously got a lot of hormonal influence. So estrogen toxicity plays a big role. So once again, going back to your genetics, if you're someone who detoxes poorly, if you're someone who has estrogen toxicity, you're obviously going to be more predisposed to that. If you had a family history of it, you're even more predisposed to that. So those play more of a role in it, to me, than a device related situation.
Okay. Okay. So, kind of one of the other things that happens within the alternative medicine industry and also within the let's put it this way, maybe social media as a whole, as folks are really blaming the devices when in fact it does sound like maybe if we should be if we're considering putting in a breast implant, we maybe should be thinking proactively about what are our genetics, what kind of detox mechanisms do we have, that kind of stuff before we actually consider a breast implant instead of folks going, oh, it's all the implants, not the actual human in that
Sure.
case.
Yeah, I get asked all the time. People try to pigeonhole me on shows and in conversations. Would I let my wife get breast implants or would I let my daughter get a breast implant? And so the discussion is more of because I understand the genetics behind it. I know how someone can detox. You would want to know that.
Hmm.
You want to know their metabolism of their sex hormones. That would help you understand estrogen toxicity better. And then, so my daughter's a Leo like me. So, despite me being able to explain anything in a practical manner, somebody's going to still make their own decisions. You just want them to make an informed decision. So, it's not about that. It's like explaining it properly and let people are going to decide. You're not going to tell my, daughter what to do when she's, 18, 19, 20, 21, 20, whatever. They're going to do what they want to do regardless. They've already probably in their head decided what they want to do, and the timing of it becomes the issue only. I can explain all the information given, my experience and try to help make a better, more shared decision, but they're still going to make their own decisions.
Absolutely. Absolutely. I think it's just something that, awareness and being aware now that we have the information going in that folks can take the information should they choose. I think one of the places in which I would look at this as to post breast cancer, maybe a total mastectomy, and someone's like, okay, I don't want to be flat going forward. Say they're 30 years old, early breast cancer, and they're going, okay, what do I do next? That would be one of the things that in my mind I would think, could that be something, that's
Well,
relevant
sure.
here.
Yeah, and that was my niche for a long period of time. From '05 to 19, I predominantly took care of breast cancer patients, and I performed a procedure called the DIEP free flap, which was a muscle sparing, nerve sparing procedure to take the lower abdominal tissue and use that instead of discarding like in a tummy tuck, use that to create a breast mount. And so that's also how I took care of patients who are had implant-based reconstructions who had infections or radiation injuries or needed to get out of that reconstructive technique for whatever reason.
Hmm.
Because it was using your own tissue, which is your own genetic material, it's not going to be rejected. You just have to have a high success rate, which we did. It was well above 95% in our group. And that was a great option. But of course, you have to have, enough lower abdominal tissue to do that. And in some people who are lower body weight and need a bilateral reconstruction, that became a more challenging problem, but can still be done.
Gotcha. Gotcha. Interesting. I mean, stuff I know nothing about, not in, not in my wheelhouse, but definitely fascinating things and questions that I get in my practice as a whole. So, I think at this point, folks are probably like, okay, cool. There's a program. We've got that kind of stuff going on. It looks, you know, incredibly, from what I've seen online, incredibly comprehensive, which I love. And I think that's fascinating. A lot of folks will ask me, Dr. Rob, who do I know? Who have I talked with? Things of that nature. And as far as I know, I haven't seen as comprehensive of a program as what you have going on. I guess my next thing to round out the podcast here, it would be if someone is contemplating explant, they kind of know they want to do one, they're looking for the right fit of a doc. What kind of things would you recommend that they look into? What kind of questions should they be asking? Things of that nature.
Well, we put together an FAQ on the on my show, Breast Implant Illness, just to answer a bunch of these, so people can just sit back and take in the things that they should know. So when they go to communicate about, surgery, like what should be looking for. So somebody who actually does them, fairly routinely. You don't want to have somebody who does one a month. I mean, I do 8 or 10 a week. So repetitions and experience obviously are always important. Um, it's not that you have to have a cancer background. You're a little bit more familiar with what you're dealing with when you're doing these removals and taking out all the scar tissue, if in fact you did that. So, like I said, when we used to take these out and convert them from a breast reconstruction to uh, a tissue reconstruction, we would take all that material out. So just like when the patient I took care of initially in 2016, I told you about, it wasn't very difficult for me to do all that because I'd done all that before. So it's not a new thing.
Mm-hmm.
Between them in the cosmetic situations, there are some, different nuances and techniques, but they're all safe. The procedure is safe. You're not gonna puncture the lung, and you're not gonna do all these things that people are worried about. So, injury, first of all, you're not gonna injure the lung at all. If you did anything, the scar can make a little uh, hole in the outside lining, which is the outside, it's not the lung itself, and it lets air in, and that won't prevent the lung from expanding. But if you get the air out and then close that, it's not going to cause the patient any harm. It's just recognizing that. That should be less than, a handful per thousand. And you can have obviously bleeding. That's the number one thing with any surgery is a problem with bleeding. So those things tend to take people back to operating rooms. That once again, that should be a handful out of 1,000. Um, there really shouldn't be problems with infections at any given rate, maybe 1%. Mine's far lower than that. I don't use drain tubes, which helps. Um, I think, having just enough experience to have a good discussion, the provider in my position should understand the concept of what the patient's describing and not belittle it or gaslight it or not recognize it. And if you're not comfortable with that provider when speaking to them about it, then that's not the right provider.
Absolutely. Absolutely. And obviously you have your podcast, which I'd love for you to speak about with folks so that folks can understand, you've got the breast implant illness podcast where you're talking all things breast implant illness, and that gives a lot more resources as well. And that can be found, I'm guessing, anywhere you find podcasts.
Yeah, it's on Apple and Spotify. Breast Implant Illness with Dr. Robert Whitfield. You just type in my full name. All the shows I've been on will pop up, and then my show will pop up that just discusses breast implant illness. And then at breastimplantillnessexpert.com, I'm sorry, at breast implant illness expert. And then we have the same URL, so you can go there and get information. I believe everything's as descriptive there as well, and links to help.
Awesome. Awesome. It's great stuff. I'm glad that you're bringing light to this, talking about it with the podcast as well, because there are folks asking at least every week in my office about their breasts, what's going on, and could there be some illness involved? So big stuff going on with that. I sincerely appreciate the work that you're doing and look forward to putting this podcast out to share more information with folks.
Thank you.
Hey, fellow health junkie, thanks for listening to the Health Fix podcast. If you enjoyed tuning in, Please help support me to get the word out about the podcast. Subscribe, rate, and review, and just get that word out. Thanks again for listening.